Good morning, everybody. Welcome to Workshop 26, What the Gut is Going On, GI Care from Top to Bottom. I'm Chris Singh, and this is Gretchen Garlow. We're going to go ahead and get started, but we have no disclosures this morning. So just put up that slide. So this morning we're going to talk, we have a variety of speakers, and we're just going to go ahead and get started with our first one. This is Ashley Deschamps, Dr. Ashley Deschamps. She is a pediatric pulmonologist at Children's Hospital and Medical Center in Omaha, Nebraska, and an assistant professor of pediatrics at University of Nebraska Medical Center. Her personal interests are cystic fibrosis and primary ciliary dyskinesia. She is going to talk to us about dietary intake and the gut microbiome in children with CF compared to their non-CF siblings.
Wow, where's your name again? I'm sorry. Shah. All right, here we go. Beautiful.
Good morning, everybody. So I first wanted to start off by saying thank you for allowing me the opportunity to present today and share this work. I have no relationships to disclose related to this presentation. So starting off with some background, we know that people with CF have significant gastrointestinal issues. These include pancreatic insufficiency, impaired nutrient absorption, gut inflammation, and bacterial dysbiosis. These issues are all important in and of themselves, but also important in the effects that they have on growth. We know that growth in early childhood is an important marker of health, and through prior research, we know that growth in early life has been linked to key outcomes later in life, including lung function, disease complications like pulmonary exacerbations and hospitalizations, as well as survival. Because dietary intake and growth is so important in our kids with CF, we have established nutritional guidelines for various stages of life. The CF Foundation has guidelines that recommend a goal body mass index or weight for length above the 50th percentile. In order to reach this goal, this typically requires anywhere from 110% to 200% of the daily recommended intake for age. To achieve this intake, children generally need to consume a higher macronutrient intake, especially fats. Their diet may be made up of anywhere from 35 to 40% fats. Approaches to achieve this goal vary anywhere from eating whole foods and healthy fats to eating high-calorie, hyperpalatable foods with maybe less nutrient density, and the use of supplements or any combination of those. Intake and growth can be a multifactorial issue, so there's multiple physiologic factors like I mentioned prior. There's also behavioral factors to consider, so picky eating, stressful mealtime behaviors, and socioeconomic factors like food accessibility and food insecurity. So it's not all up to us as humans. We have trillions of bacteria in our gut, and these bacteria serve important functions in the gut. They aid us in nutrient metabolism and energy harvest. They also influence function of the immune system. We know that in people with CF, they have alterations in the gut microbiome that include a decreased relative abundance of commensal fermentative bacteria, including Bifidobacterium, Clostridium clusters, Faecalibacterium prausnitzii, and Ruminococcus bromai. Along with this decreased abundance of these fermentative bacteria, we have altered fatty acid metabolism, especially short-chain fatty acids, which include acetate, butyrate, propionate. Short-chain fatty acids are important in the gut as they're used by colonocytes for energy and also have a role in intestinal barrier function. They are produced when anaerobic gut bacteria ferment complex resistant carbohydrates in the colon. Also, in people with CF, they have an increased relative abundance of pro-inflammatory or potentially pathogenic bacteria, including proteobacteria and enterococci. And these can be correlated with markers in the stool, including fecal fat content and fecal calprotectin. It's not all bad news, so these issues all provide some opportunities for intervention. In theory, by increasing the levels of fermentation substrates, we could potentially increase the abundance of more beneficial microbes and the production of short-chain fatty acids. Some possible avenues for these interventions would include prebiotics, synbiotics, which are a mix of pre and probiotics, as well as possible dietary interventions. And so in our study, we had the following objectives: to evaluate the composition of the intestinal microbiome in children with CF compared to their siblings without CF, assess dietary intake and gastrointestinal symptoms in these two groups, and evaluate the association between the intestinal microbiome and dietary intake of fat and fiber. In order to do this, we recruited children with CF and their siblings without CF from our local CF clinic over the course of 3 years, from 2018 to 2021, with a pandemic intervening in between. They filled out a youth adolescent food frequency questionnaire to assess their dietary intake. Stool samples were collected by families at home using an Omnigene gut tube that has a special preservative in it to preserve the bacteria in the sample. The samples were returned to clinic, aliquoted, and frozen at -80. Once we had enough samples, they were batched and bacterial DNA was extracted, and 16S rRNA gene sequencing was performed on the MySeq Illumina sequencing platform, and statistical analysis was done using R package. So diving into our data, here's a table of our clinical characteristics. We had 23 children with CF, and we had 10 siblings without CF. 65% of our kids with CF were male, whereas 90% of the siblings were. The median age in the children with CF was 6.9 years, and in the siblings, 8.2 years, with quite a range. The majority of the kids were Caucasian. Just over half of the kids with CF were homozygous F508del. The majority, 87% of the kids with CF, were pancreatic insufficient. The median BMI percentile in both groups was above the 50th percentile, with 56th percentile in the children with CF and 58th in the siblings. And then 65% of the kids with CF were on CFTR modulators at the time of the study. So looking at macronutrient intake, so there are 3 main macronutrients that we all have in our diets that make up the calories in the foods we consume. These include carbohydrates, excuse me, fats, and proteins. For our children with CF and the siblings, we can see the carbohydrates displayed in the orange color, and so about just over 50% of their intake came from carbohydrates. Fats are in yellow. Both groups, 33% of their intake was from fats, and then the remainder in blue was from proteins. Next, we looked at whether their intake was sufficient based on the gold DRIs. And so in this table, we have the group split out, the children with CF and their siblings. We have them at all ages, and then also broken into age categories, as the DRIs do vary based on your age category. In our kids with CF, 87% of them had sufficient caloric intake based on their gold DRI. If we look at the macronutrients and where they might be lacking, the biggest deficiency was in their total fats. Only 83% of them were meeting their total fats. In our siblings without CF, 100% of them were meeting their caloric goals, and they were all meeting their macronutrient intake as well. In the bottom row, we have total fiber. So only 43% of the kids with CF and 40% of the siblings without CF were meeting their recommended fiber intake. Next, we looked at gastrointestinal symptoms. The children with CF are in orange, and the siblings without CF are in blue. Not surprisingly, the children with CF had frequent gastrointestinal symptoms. The most common ones that they reported were excessive gas, abdominal pain, bloating, diarrhea, and constipation. The siblings without CF also did report some gastrointestinal symptoms, most commonly constipation in 50% of them, and to a lesser extent, diarrhea. Next, looking at our microbiome data. So first we looked at the groups with their microbial beta diversity. So beta diversity looks at between group variability within the microbiome. And we saw that the groups tended to segregate based on disease process. So the children with CF are the blue dots in the blue circle. And we saw that the kids with CF were more similar to each other as a group than they were to their siblings without CF, which are displayed in the red. Next, we looked at alpha diversity using the Shannon index, which gives us a measure of the evenness and richness of the bacteria within the microbiome. On the left, we have the children with CF, and the right, we have their siblings without CF. We can see in the children with CF, they had a lower Shannon diversity compared to their siblings, and with this lower Shannon diversity means lower overall diversity. When we break this down a little bit in more of a detailed fashion, looking at differences by taxa, we have this displayed in this figure here. And so the phylum is represented in the colored dots. So the firmicutes are red and the proteobacteria are green. Along the bottom of the figure, we have the different genus that are within those phylum. And so in the kids with CF, they had increased proteobacteria, including Klebsiella and Escherichia and Shigella. They also had some increased firmicutes, including Salmonella and Tizarella and Streptococcus. In the siblings with CF, they had more firmicutes, including Lactospiraceae, which is an anaerobic bacteria that's an important short-chain fatty acid producer. Next, we evaluated whether there was any relationship between diversity and the different intake of fiber, which is on the left, and fat, which is on the right. The colored bars represent the two groups, so children with CF are the red line and their siblings are the green line. And we saw that with both fat and fiber intake, it did not significantly correlate with the Shannon diversity in either of those groups. Lastly, we looked at statistical modeling of the abundance of individual taxa and their association with dietary fat and fiber intake. These are displayed here using a taxonomic association tree plot. Regression coefficient estimates and p-values are shown in the colors and then the open circles. The gray figure on the left is the key, and then the more colored figures on the right are the analyses. We saw a positive association between fat and Bacteroideaceae, and an association between fiber with proteobacteria, specifically Pasteurellacea, and a few varieties of firmicutes. So from this data, we drew the following conclusions. The majority of participants met their caloric and macronutrient goals with a median BMI percentile, a median BMI greater than the 50th percentile in both groups. Fiber intake was below the DRI in both groups, which really provides an opportunity for counseling and potential interventions. Participants with CF had a lower intestinal microbiome diversity with higher abundance of proteobacteria. And though fat and fiber intake were not associated with intestinal microbiome diversity, there were associations with particular taxa. The next steps for us in this study involve in vitro fermentation experiments, which are ongoing. In these experiments, we'll evaluate the changes in the intestinal microbiome using 16S rRNA gene sequencing following fermentation with prebiotic substrates, and we'll also measure the short-chain fatty acid production. I'd like to acknowledge my research team who helped to make all this work possible, as well as the participants and their families for collecting fecal samples, which is not always a glamorous job. And I'll take any questions. Thank you.
There's some time for questions.
There's a microphone right here. You can just step forward. Or you can enter a question on the app.
You guys are gonna make this easy.
Hi, my name's Carissa. I'm the dietitian from UW Medical Center in Washington State. I was curious if in your data you have available the types of fats and fiber that children, the composition of fat and fiber that children were eating.
Yeah, so in these analyses, we use total fat, but we do have like saturated and unsaturated fats, which after listening to other presentations and people, I think will be important. And so we can definitely go back and look at those particular components.
I'm Senthil Sankaraman, a pediatric gastroenterologist at Rainbow Babies. First of all, excellent work. Congratulations. My question is, as we all know, children with CF, they get antibiotics so frequently. How did you control it? And then second question is acid suppression. So did you account that for PPI or H2 blockers? Thanks.
Yeah, so we do have whether or not they were on antibiotics at the time of sample collection and also PPI. This data thus far is not controlled for those factors, but I think as we go to like further analyze and publish it, we will need to do that. It's also a small sample, and so once you start controlling or separating out so many things, it gets a little complicated.
Yeah. Thank you.
Hi, my name is Joshua Kaloff. I'm a pediatric gastroenterologist at University of South Florida in Tampa. Great presentation, very interesting comparisons. I did have a couple questions. Did you see that the siblings had any obesity? You know, if the parents are so used to pushing higher calories on the siblings, did you notice that the siblings who have pretty similar distribution of fats, proteins, and carbs in their diet, were they higher weight? And then my second question is, did you ask any questions about supplements such as fish oils, probiotics, or anything like that?
Yeah, good questions. So the median BMIs of the siblings were similar to the kids with CF, and so we didn't see, you know, extreme or a preponderance of obesity in those kids. And then we do also have information about supplements, whether those were like formula type supplements or probiotics and things that we also can control or account for as we move forward in analyses.
So we have one question. Does changing the free fatty acids in the diet using supplements like coconut oil impact the gut microbiome?
So we didn't specifically look at the particular fats, and so the analysis was just total fat. And this sample, we did not see any difference. I think if we separated out certain fats, potentially.
And is there a plan to compare the microbiomes in children before and after starting them on ETI therapy?
So I think that there's other groups that have done that work and even published on that work. It wasn't a particular aim of ours, and we would be able in maybe a subset of our sample to look at it, because right around the time we were doing the study was the time that a lot of people were starting like Trikafta or more modulators. And so we'd have kind of a small group pre and post.
Okay. And then one more. Do IV antibiotics affect to the same extent the gut microbiome as oral antibiotics?
It's a good question, and I don't know, and we don't have that in our particular data set, but I think important things to consider as we use antibiotics.
Thank you so much.
Thank you. That's great. Okay, we're going to be moving on to the next presentation. I'd like to introduce Bailey Hamner. Bailey is a fourth-year medical student at the University of South Florida, Morsani College of Medicine. in Tampa, Florida. And she is going to talk to us today about the prevalence of acid blockade use and its association with social determinants of health amongst patients with cystic fibrosis. And this is a preliminary analysis from the CF Foundation registry data.
Okay. Good morning. Thank you for the introduction, and thank you so much for having me. So I'm going to talk to you a little bit about this and acid blocker use and social determinants of health. This work was supported in part by grants from the Cystic Fibrosis Foundation, as well as a research grant from my home institution. So starting with a little bit of background, acid blockers are very commonly used in patients with CF. This here is some graphs from the CF Foundation's annual registry data report. So on the left here in the gray, we have all patients with CF. Then in the blue, we have those using acid blockers, PPI specifically, and then in the red, we see H2RAs. Notably, H2RAs are more prevalent in the first few years of life. A lot of GI doctors prefer H2RAs under that age. And then we see a steady rise in PPIs into childhood and then steady throughout adulthood. You can see by the time patients are about 20 years old, at least 50% of patients are using a PPI with an additional 10 to 20% using an H2RA. So we know that at least 50 to 60% of patients with CF are taking acid blockers by the time they're 20. So why are these so commonly used in patients with CF? The number one reason is to treat gastric reflux. This is a really common GI complication in these patients. The other thought is that they might improve pulmonary function. So GERD is hypothesized to cause microaspiration or airway inflammation in patients with CF. So it's thought that reducing that acid will help improve pulmonary function. And thirdly, there's some studies that suggest that reducing the amount of acid in the gut might promote pancreatic enzyme absorption. And importantly, a lot of these kids are on pancreatic enzyme replacement therapy. But there are some kind of limitations and concerns. So firstly, there's increasing evidence for significant side effects with long-term PPI and H2RA use, which we'll talk about in a second. And then these last two kind of uses have more limited and contradictory evidence. So there's some small studies that back these up, and then some other ones that don't find the same findings, and they've all been kind of small single center studies. So what kind of side effects come with long-term PPI or acid blocker use? So two main categories that we worry about in patients with CF. Number one is their nutritional status, and number two is their pulmonary function. So some side effects on nutritional status include increased rates of GI infections, nutrient deficiencies, to name a few. And in terms of pulmonary health, they've been linked to increased number of pulmonary exacerbations, hospitalizations, and infections like Pseudomonas. We know that nutritional status strongly influences pulmonary health in these patients, meaning that these adverse effects may be compounding one another. So how do social determinants of health factor in? So we know that these determinants affect access to care, including the rate at which medications are prescribed. This has been a long-standing problem with old and new studies demonstrating consistent results among patients with CF, showing that they're strong predictors of disease severity, with things like lower income, no insurance being associated with worse BMIs, worse FEV1s, and even higher mortality rates. So what are our knowledge gaps? We want to know what are the population level effects of acid blockers on nutritional and pulmonary health in patients with cystic fibrosis. We want to know what is the impact of how long they're taking acid blockers on those outcomes. And we want to know what association, if any, exists between social determinants of health and rates of prescribing acid blockers specifically. So we aim to address these knowledge gaps with a large retrospective cohort study using data from the Cystic Fibrosis Foundation patient registry. We want to investigate associations between the use of acid blockers as well as the duration of the use of those medications with pulmonary outcomes via FEV1, nutritional outcomes via BMI and weight for length Z-scores, and we want to analyze social determinants of health as modifiers of aims 1 and 2 via annual income, race, ethnicity, and sex. So as I mentioned, we're using the Cystic Fibrosis Foundation patient registry. This is a national registry that collects data from CF patients at CF care centers around the country. Our exposures of interest are acid blocker use and duration of use. As stated before, we want to look at BMI for nutritional outcomes and FEV1 for pulmonary outcomes. And then some of our covariates are those social determinants of health, as well as the severity of their genotype and the age of the patient. We included all patients under 21 years or 21 and under who were seen at CF care centers between the years of 2005 and 2020. We excluded those patients who had a history of solid organ transplant or who were pregnant. For our univariate analysis, we used a p-value of 0.05, and for our multivariable with a p-value of 0.01 to control for type 1 errors. We used multiple regressions to test the relationship between duration of acid blocker use and each of those two outcomes with BMI, Z-score, and FEV1, adjusting for other patient characteristics. So to get started, on preliminary analysis, almost 30,000 patients with CF met our inclusion criteria. On average, between the years of 2005 and 20, those patients were on acid blockers for about 5 years. I'm going to orient you to this graph. So on the left, we have those predictors we discussed with sex, income based on federal poverty level, and then race and ethnicity. On the middle graph here, we can see the breakdown between those groups. So for sex, it's about 50-50 between females and males. We see that income, the largest group is in the highest income level. And with race and ethnicity, the largest group is our white non-Hispanic patients. On the right here, I broke down what % of those groups were on acid blockers or who had ever taken acid blockers. And we can see here that pretty consistently, at least over 67% of those patients had taken acid blockers at least once in their life. When we looked at mean BMI Z-scores, mean FEV1, and mean age between those groups who were never on acid blockers versus who had taken acid blockers, we saw that patients who had taken acid blockers had lower BMI Z-scores, lower FEV1s, and were older on average. So I'm going to orient you to this graph. So on the bottom here, we have the year of data collection. On the y-axis, we have the proportion of the year somebody spent on acid blockers. So for example, in 2005, patients typically spent about 50% of the year taking acid blocker medications. We see overall it's been kind of a steady rise and then been stable past 2011. It was slightly decreased in 2019, and notably that was the rise of highly effective modulator therapies. Similar slide looking at average BMI and weight for length Z-scores per year. The 0 is the line for the 50th percentile. And that's notable because in 2008, the CF Foundation set BMI goals at the 50th percentile due to the positive correlation between BMI and lung function. So we're seeing on average the mean BMI Z-scores have steadily increased past 2003. They've been mostly above the 50th percentile, and we see another jump here in 2019 with the rise of highly effective modulator therapies. This is average FEV1 based on % predicted values. So we see that there's again been steadily rising over the years due to improvements in clinical care, and again this jump in 2019 with highly effective modulator therapies. So this is our univariable analysis. First, we're going to look at BMI and weight for length Z-scores. So we saw that female sex was associated with higher BMI, and that was a statistically significant difference. higher income levels were also significantly better, had a significantly better BMIs than those in lower income groups, with those in the highest income class having the highest BMI Z-scores. And then when we looked at race and ethnicity, we saw that those who were Hispanic ethnicity had higher BMI weight for length Z-scores than those who were non-Hispanic. And when we looked at our genotypes, we saw that those with low risk mutations had better BMI Z-scores. For FEV1, we actually found no difference between sexes in FEV1s. We did find, again, that higher income was associated with significantly higher FEV1s. When we looked again at race and ethnicity, we found that those non-Hispanic patients had better FEV1s when compared to Hispanic patients. And again, those with low-risk genotypes had better FEV1s than those with more severe mutations. So in our multivariable analysis, we held constant all the variables that were significant in the univariable analysis. So when we looked at BMI, we saw higher BMIs with longer duration of acid blocker use, younger age, higher income, low risk genotypes, and female sex and Hispanic race. When we looked again at FEV1s, again holding all the other variables constant, we found higher FEV1s with longer duration of acid blocker use, younger age, higher income, low risk genotypes, and those non-Hispanic patients. So that was a lot of numbers and graphs. So let's just summarize that real quick. So we found that when controlling for other factors, higher BMI and weight for length Z-scores were significantly associated with longer duration of acid blocker use, younger age, higher income, low risk genotypes, Hispanic ethnicity, and female sex. We saw higher FEV1s, again, with those who were using acid blockers for longer, those who were younger, those in higher income groups, and with low risk genotypes. And interestingly, there was a difference between BMI and FEV1s. We saw better FEV1s with non-Hispanic ethnicities, and that there was no association with sex. So what can we kind of summarize from what we've learned? So we found that acid blocker use is prevalent amongst patients with cystic fibrosis. Pediatric patients were typically on acid blockers for greater than 50% of the year. And we also saw that over 67% of all patients had been prescribed acid blockers at least once. We saw that patients who are younger, have low-risk genotypes, and use acid blockers for longer appear to have better BMI, weight for length Z-scores, and FEV1s. We also found that social determinants of health are significantly associated with FEV1 and BMI, weight for length Z-scores. Patients with CF in lower income groups had consistently worse BMIs and FEV1s, even when we controlled for those other factors like the severity of their gene mutation. And we also saw those discrepancies between groups where Hispanic patients had higher BMI and weight for length Z-scores, but lower FEV1s. And we found that female patients had higher BMI, weight for length Z-scores, but similar FEV1s when compared to males. So we're still working on our analysis. This is ongoing. We are looking at additional measures of pulmonary and GI outcomes like pulmonary exacerbations, FVC, GI complications, number of dietitian visits, and number of home hospitalizations or home IV nights. There are also a lot of other confounders that this has not yet controlled for, like pancreatic enzyme replacement therapy and additional supplemental feeds, infections, use of antibiotics, comorbidities like liver disease or CF-related diabetes, and very importantly, whether or not somebody was using highly effective modulator therapies. I want to say a big thank you to the Cystic Fibrosis Foundation for their use of the CF patient registry. And we'd like to thank the patients and care coordinators at CF centers across the country. Thank you to our incredible research team, and a special thank you to Olga Dorkina and Ellen Towler for assisting us with the data analysis. I'll take any questions.
We have a couple of questions here.
Okay.
Oops. No, those are from the audience. Don't be shy. Did you differentiate between patients that were on PPI inhibitors versus H2 blockers?
That's a great question and something we've talked about a lot. Right now, we did not differentiate between the two. We found that H2RAs, consistent with the graphs we saw from the CF data, the yearly annual data report, that H2RAs were more common in the first 2 years of life, and then from then on, patients were mostly taking PPIs. Thank you.
Thank you.
No, I think she's on this list. All right.
Our next speaker is Carolina Trocina. She's a resident physician at Johns Hopkins All Children's Hospital.
Well, good morning, everyone. I just want to say thank you so much for having me here. I really appreciate the opportunity. I'm Carolina Trocchi. I'm a third-year pediatric resident at All Children's Hospital in Florida, and I'm very excited to share my research with you today entitled Utilizing the Trinetics Global Health Database, and we're going to look at associations of GI manifestations and venous thromboembolism in cystic fibrosis, and we are going to use that VTE symbol throughout this. This is my disclosure slide. I have no financial relationships to disclose. And this work was made possible through the support of the Cystic Fibrosis Foundation, as well as an institutional grant at my home institution. So allow me to orient you to this figure here. So this figure was made available through the Galaxy study, which is a study that had included 402 eligible patients, 42% of which were pediatric, and that included ages 2 to 18. So on the y-axis here, we have our pediatric assessment of patient-reported outcomes for GI symptoms, and on the x-axis, it represents the proportions of symptoms at the time of enrollment per patient response. So the pink bars that you can see here reflect pediatric responses, and the blue bars reflect adult. And overall, what this is demonstrating to us is that there are a high reported GI symptom burden in both populations. But what I've identified here with these stars is that there are noticeable responses in the pediatric population for the symptoms of straining, stomach fullness, and incomplete bowel movements. So this figure here, so we know that there are numerous CF genotypes and that the CFTR gene is expressed along the GI tract. So thus, this could potentially lead to impaired function all throughout the pancreatic tract, and this was made possible through Dr. Satti's work. So what I want to be able to pull from this slide is that we're going to categorize some of these conversations of GI manifestations into 3 different categories. So first is looking over to the left here, we could see that with impaired CF genotype can lead to impaired pancreatic secretions, and that could lead to diagnoses such as EPI or exocrine pancreatic insufficiency, as well as pancreatitis. In the middle, we have potential for impaired biliary function, which could lead to hepatobiliary disorders, including things like cholestasis, as well as liver diseases. And then on the right, you could see that there is an altered viscosity of the mucus along the intestinal lining as well, which could potentially lead to diagnoses such as obstruction and impaired motility. And collectively, all these together could lead to both specific to the inflammation, both specific to the GI tract as well as systemic GI inflammation. So essentially, I just want to use this as a conceptual model for these 3 categories of diseases, and then remembering that there could be a potential for inflammation. So that leads us to a slightly different conversation here, where we're thinking about now systemic inflammation, and that inflammation could potentially lead to other adverse outcomes outside of the GI tract. So previous research at Children's Hospital of Colorado had demonstrated that there is actually an increased incidence of VTE, so venous thromboembolism, in children with CF, and that was done through a single institution retrospective review from 2003 to 2016. And really 2 different larger variables were identified to contribute to this. So that was chronic systemic inflammation, as well as use of central venous catheters. And then there were some sub-variables to support these overall concepts. But essentially, these 2 both contribute to the presentation of thrombosis. So this brings up the question that CF patients are at a unique risk for a thrombosis event. And then together, this raises the concern that that systemic inflammation from potentially GI disease could pose a risk of a VTE. So here we identify our knowledge gaps here. So as we've previously seen, there are prior studies that do describe the burden of GI symptoms, but not necessarily focusing on specific diagnostic GI disease. And then there is a lack of multi-center data that's looking at the prevalence of VTE specifically in the pediatric CF population. And then thirdly, despite the role of inflammation within GI disease, there's no known association between having a GI disease and VTE within this particular population. So this does bring us to our study aims here. So we have aim 1. So we're first going to look at and describe the prevalence of GI manifestations in children, and we are using birth to 21 with CF, and we're going to use a Trinetics database to do so, and we're going to explain a little bit on that as well. For aim 2, we are looking at the prevalence of VTE, specifically within the CF population. And then finally, for aim 3, we're going to identify the underlying CF-related gastrointestinal manifestations and break them down into these 3 subcategories, and then see if there is an association with VTE in children with CF. So just a little comment on the use of the Trinetics database. So we chose to use this as it is unique. So some features about it, it is a global health data that provides real-time access. For our study, we're actually able to receive data from 67 different healthcare organizations. And it does include patient-protected information, and that comes from both inpatient and outpatient centers. So the data is automatically harmonized and will be reviewed by ICD-10 code. However, depending on the duration of the study, there is an algorithm to correct for ICD-9 codes as well. And there's also a greater ability to focus on GI diseases, but you can actually extend to looking at things like labs, procedures, medications, et cetera. So this is, so we chose to use this in comparison to potentially a CF registry, which does provide very broad data and looks at pediatric patients age 2 and greater, but does have patient opt-in. So methods for this study. So our inclusion criteria for our cases compared to our controls. So our cases were from birth to up into and including age 21 with a diagnosis of CF. And we looked at a 10-year period from January 1st, 2010 to January 1st of 2020. And then our controls are those without CF. And then our exclusion criteria are those with solid organ transplant. So the way that this was performed is essentially looking at a data query using the ICD-10 codes within the database itself, and that was stored at our institution through the clinical data acquisition process. And the way that we had performed our statistical analysis was for continuous variables, we had used a simple t-test. For categorical variables, we had used the chi-square or the Fisher's exact test. And we also included the Bonferroni adjustment due to multiple comparisons, which shifted our p-value to being a significance of less than 0.0001 from 0.05. So we're going to look at the results for AIM-1, which, just as a reminder, is looking at the overall prevalence of GI disease in pediatric CF. So for our demographic table, so we had a total number of 7,649 children that had CF and greater than 22 million children without CF that met criteria using this database. And what we want to highlight here is that there is a statistically significant difference in age as well as race and ethnicity between these two groups. Of note, with race, what we see is there's a greater overall portion of the Caucasian population and those with CF, and for ethnicity, a greater number of non-Hispanic or Latino. And this is reflective of what has been seen in what is known in the CF population. And for comparisons, we're going to use this value as reminded. So allow me to orient you to this table here, and we're going to use this as a model for the coming slides as well. So what we see is on the left-hand column reflects the ICD-10 codes. And the middle, what we're looking at is the number of patients with a CF history with this particular GI diagnosis. And then on the right, we're looking at our non-CF group that has this diagnosis as well. And for this first slide, we're going to look first at the pancreatic diseases that we're seeing. So the most common GI diagnoses are highlighted here with our two red bars here. And what we see is that there are some group categories that essentially reflect that broad selection by practitioners and use of broad codes that may reflect things like chronic pancreatitis or exocrine pancreatic insufficiency. But I also want to comment on the fact that there is a greater significance and prevalence of acute pancreatitis as well. So overall, there's a greater number of pancreatic disease in the pediatric CF population versus non-CF. So here again, we're going to use that same model for our table, but now we're going to discuss the hepatobiliary diseases. And what we can see is that the most common that are highlighted here would be diseases of the liver, and they all share this common theme of being essentially a nonspecific liver disease code. And this might suggest the heterogeneous nature of CF liver disease and the fact that there is no specific CF-related liver disease diagnostic code. Overall, though, what we're seeing, again, here, like pancreatic disease, is that there's a greater number of hepatobiliary disease in our CF population. And our last category here, for looking at AIM-1, is we're now looking at intestinal diseases, and here we could see the most frequent that are listed from top to bottom. Again, the top three being constipation, GERD, and G-tube status. So, but again, overall is what we're seeing, a greater number of intestinal prevalence in the CF patients versus those without. So given the nature of the database, we were actually able to extend to a couple other features rather than just looking at diagnostic codes alone. So we extended it to look at medication use, and we'll look at procedures as well. So beyond the diagnoses, the most common GI medications that are used are digestants and laxatives. And then we're also going to look at the third case on the next slide. But what we see here are descriptions of some of the different types of laxatives that we're seeing. But again, in comparison to our CF and non-CF groups, there's a greater number of use. And then thirdly here, what we're seeing is the use of gastric medications as well. And this includes both PPIs and antacids as well. So lastly here for AIM-1, we're able to look at GI procedures as well. And what we're seeing are the most common that were performed within our CF group was an EGD, surgical procedures, as well as colonoscopy. And again, the overall prevalence was greater in our CF versus non-CF group. So now I want to move on to looking at the results for AIM-2, which is essentially discussing venous thromboembolism, or VTE, in CF. So here we have our demographic table, and although I don't have it specifically identified here, we did make a comparison of prevalence of VTE in CF and non-CF patients and found that overall VTE occurrence is greater in the CF population. Here we could see that 2% of CF patients had VTE occurrence, and that our race was significantly different between the CF population, both with VTE compared to those without VTE. So this table here, I'm going to kind of reorient us. On the left, we're now looking at specific known risk factors for presence of VTE, and then we're specifically looking at those with CF if they had a presentation of VTE or not. And what we see here are listed values, or listed variables, excuse me, that are statistically significant that are known VTE risk factors. We did look at anticoagulation medications as well, but that was not viewed to be significant. And then lastly, we're going to look at our AIM-3, which is essentially looking at the association of GI manifestations and presentation of AVTE. So we're going to go back to our first category here of GI diseases and looking at our pancreatic diseases. And what we see here is that amongst the pancreatic diagnoses, acute pancreatitis was the only significantly associated GI disorder in CF with presentation of VTE in comparison to EPI or chronic pancreatitis. For liver disease, again, what we had identified and discussed before was that some of the most prevalent liver diseases in CF patients were kind of nonspecific. So what we see here is that the specified disease of the liver as well as fatty change of the liver had the greatest prevalence in those with VTE compared to those without. So we do see some association with liver disease. And then lastly, when looking at intestinal diseases, what we're seeing are constipation, GERD, gastrostomy status, as well as nonspecific gastroenteritis and colitis. And then this also includes impaction and esophagitis as intestinal disorders that are associated with VTE in patients with CF. So looking at our conclusions here, so for AIM-1, when we're just looking at the overall prevalence of GI disease, what we actually see is in terms of prevalence of GI disease, medication use, and for procedures are significantly higher in pediatric patients with CF compared to those without. So really this leads us to consider the GI burden of disease in pediatric patients beyond just pancreatic insufficiency. And we are aware too that this is a descriptive study, which includes its own limitations, and since this is ICD-10 based, there may be some discrepancies in terms of codes that were placed, in terms of accuracy or specificity, as we mentioned. For AIM-2, so we had seen that there was overall a greater number of VTE occurrence within the CF population, but also that there's a significant association between the risk factors that are listed below and VTE within this population. So that includes placement of a central venous catheter, bacteremia, as well as bacterial pneumonia. We also specifically looked at Pseudomonas, as this is particularly high-risk population for that infection, and as well as pneumonia with other gram-negative bacteria. And then use of medications, we looked at glucocorticoids as well as systemic contraceptives, as those are known risk factors for VTE presentation. And then for AIM-3, what we had seen is that within each category that we had reviewed for GI diagnosis, there are a greater number of these codes within those that had both CF and VTE. So for pancreatitis, we had noticed for acute pancreatitis. For hepatobiliary, we had seen this in liver disease as well as fatty changes of the liver. And for intestinal, we had seen these below as well. So for potential future directions for our work, so if you recall, we did use a time frame that was from 2010 to 2020, and there are implementation of the modulators was in 2019. So we can consider comparing the prevalence of GI diagnoses pre and post use of highly effective modulator therapy. And then otherwise, we can also focus on perhaps digging a little bit deeper into some of these GI diagnoses that we had seen and assessing the role of inflammation in these patients with CF as well as VTE presentation. So I would like to acknowledge and thank my primary mentor, Dr. Rasha Khalaf, as well as my entire research team at All Children's. They have been wonderful to work with. And then also working with the Trinetics database has been a fantastic experience as well. And then for all the patients who had contributed their work to us. So thank you for your time, everyone. Happy to take questions.
Can you tell us a little more about the Trinex database? Who maintains it, and how is the data collected?
Sure. So the information, the patient information. I will try and go back if I can to that slide so we can look back at that. Okay. Oh, sorry. Give me one more. Okay, so some of the features, just to highlight them again here. I'm not as familiar in terms of maintaining, so I know that it is a private global database that is used, but the information's, part of the information reason that we had used this as well was that the patient information doesn't automatically have to, or it's automatically included and doesn't have to be opted in specifically, but I'm less familiar in terms of how the.
So is it gleaned from insurance? Or from?
I believe it's pulled from insurance, but I'm not sure in terms of if it's directly pulled from. Right, exactly.
Just billing codes.
Exactly.
But you don't know who maintains the database?
I'm not sure myself.
Just curious.
Okay, we have a question here. Did you assess prevalence of ET occurrence when pulmonary exacerbations, infections occurred in tandem with GI diagnoses? Or were there IVs versus PO antibiotics for use at the time of ET event?
So we did not specifically control for those things, but I think it is worth noting for those particulars, as those are also known risk factors as well. So I agree. I think that's worth noting, but we did not for this particular study.
And did you pull out anything by year, just given that some of this went into the pandemic and just with COVID-19? I know it goes to the end of December 2020. So any look at that at all?
So we didn't look specifically at COVID too, and we extended it to January 1st of 2020 to try and hopefully mitigate a little bit of that influence as well. But I think that could be a potential interesting study, especially looking future with pre and post and considering that as a potential variable as well too. Sure. I agree. Thank you.
Wonderful. Thank you so much. Great presentation.
No worries. Alright, who's next? Oh, Mark. Right. There you go. 1 second. Beautiful. If they two questions, if they start looking towards you, make sure they talk about.
Okay.
And our last presenter will be Jennifer Burke. She's a nurse practitioner at Rush Children's Hospital. Jennifer's special clinical interest is in ventilator management and development of personalized plans to maximize lung health. She's been a part of the Aerodigestive Clinic since its inception, and she enjoys the in-person collaboration with families and providers. She's been at Rush as the clinic coordinator at Rush Children's Hospital Cystic Fibrosis Center for more than 14 years. Jennifer.
Thank you. Good morning, everybody. Thanks so much for asking me to come speak with you today for our little slideshow here. I have no disclosures. And of course, I do the wrong thing to make the slides go. This. There we go. So I'm here today to talk to you about the effect of low versus high dose pancreatic enzyme supplementation on BMI in people with cystic fibrosis. That we just did is at our children's part of it, but people were up to age 20. So why did we decide to look into this and see what we were doing? Well, when we looked at our center-specific data report, we noticed that going back to 2013 and every single year, we were below, kind of well below what the national average was for people taking enzymes. So that prompted a discussion on our team. Why were we so low? Should we be so low? Should we increase enzymes on people just arbitrarily to make sure we're not staying too low? Do we go up on their dosing regardless of their symptoms? So we decided to make it official and actually do a full study with it and compare the BMIs of the patients on high versus low and see what that data told us. The enzyme replacement therapy recommendations from the Cystic Fibrosis Foundation talk about doses of enzymes exceeding 2,500 lipase units per kilo per meal warrant further investigation, and they don't recommend going higher than 6,000 lipase units per kilo per meal. It's not clear if doses greater than 2,500 are even safe, and it's unlikely that higher dose enzymes will improve clinical conditions in patients, including growth. So looking at these guidelines, recommendations say not to exceed the 2,500 units lipase per kilo per meal. And if you add that up together for 3 meals a day, it comes out to about 7,500 units lipase per kilo per day in patients. We didn't include snacks on patients because it's just so variable depending on if their kids are at school, if they're not in school, when they can get snacks in. And the 7,500 units lipase per day just kind of made a good middle of the road number for patients. We had a small N in our unit. It was only 13 patients that we had who qualified for this as having under the age of 21 and being pancreatic insufficient. But it broke down nicely for our patients right about down the middle. About half of the patients were taking more than the 7,500 units lipase, and about half the patients were taking less than the 7,500. So it worked out well for us. Our methods for this. We did a chart review of our patients back of all of 2022. And so any patient who had a clinic visit with us and was listed as being pancreatic insufficient and less than 20 years of age, we just took the last BMI that they had noted in their chart for the most recent visit of the year, whenever that was, and looked at the units lipase documented for that year as well. And like I said, the 7,500 units lipase per kilo per day was the cutoff for that, for going above and below. And thankfully, our rockstar dietitian likes Excel sheets and had all of this data right there for us, so we didn't have to scour through any charts. And what did we find when we looked at that? Well, nothing was statistically significant for them, but I found it interesting that if you just take a nice breakdown of our patients who were on less than 7,500 units lipase per kilo per day, their mean BMI was much higher than the patients who were taking more than the 7,500 units per day. But does that mean that it's better because those patients are less sick and have less GI symptoms? We didn't kind of suss that out. We just really looked at the hard numbers of exactly how many units they were taking. So nothing was statistically significant. Our p-value was 0.6. The mean BMI was greater in patients taking the less than 7,500 units. It concludes that dosing higher than the CFF recommended guidelines for that would not be beneficial to any of our patients. And it kind of reinforces their statement that it's unlikely that higher enzyme dosing will improve clinical outcomes for patients. So we kind of proved our point there, and then we're able to come back as a team and say, nope, we don't need to just arbitrarily increase dosing for patients who are on the lower side. And some things to consider. It brought up good conversations within our center. What alternatives are there to increasing enzymes in patients when they're nearing max dosing, meaning approaching that 10,000 mark or even over that 10,000 mark sometimes? Making sure that those patients are hooked in with a gastroenterology specialist, somebody who's familiar with CF disease. Make sure they're being worked up for other alternative things. Just because they have cystic fibrosis doesn't necessarily mean that's the one thing that can be causing all of their problems, and kind of looking outside the box to help those patients. And now we need to talk about decreasing doses on patients. I think, at least as I grew up with cystic fibrosis, we never talked about decreasing doses on patients. It was always, they were kids, they were growing. Do we need to go up? Do we need to go up? And now that kids are on modulators or are doing well or are showing great growth velocity with a BMI, do we say, hey, let's try decreasing their doses of enzymes and seeing what kind of effect that has on the patients? I know patients would be happy to be taking less pills a day, so I think that's something we need to talk about for every patient and every visit, like we do, instead of talking about going up all the time, thinking about maybe going down on those things. And then going back to the modulators, I think we've all been seeing that patients are gaining good weight and not having the GI symptoms that they used to be having in the past, and making sure that patients who are on modulators, that's much more closely monitored for them with that. And that is my short and sweet presentation. Did anybody have any questions?
Did you look at changes in, what I was interested in is who manages the enzyme dosing at your center? Is it your dietitian? Is it the physicians? Is it the nurse practitioner?
It's kind of a collaborative effort between everybody. So we do a huddle for our patients before we see them, which involves our GI doctor, our dietitian, and our physicians, and myself as a nurse practitioner. And so we go through each specialty, and so we'll say to the GI and the dietitian, like, hey, what do you think about this patient's enzyme dosing? Are they on too much or are they on too little? And then we kind of make a decision together about where we need to go with that. Works out nice.
Yep. We can't hear you. Guys, hello?
Can someone help with the mic for questions?
Hello.
There you go.
Okay. Hi, my name is Sarah. I'm a dietitian at Helen DeVos Children's Hospital in Grand Rapids, Michigan. More of a statement rather than a question, but when we got our annual review, we noticed that we also had very low levels of lipase compared to, kilograms, and we also had that question of, should we be concerned about this? And when we evaluated our BMI trends, we noticed that, many of our kids are over that 50th percentile and are doing really, really well. So I just wanted to, say thank you for looking into this and presenting today, and knowing that, despite that, things are still going okay.
Yeah. Thank you. It's good to know other people are seeing the same data results.
Yep. I have, this is just a comment. I have a philosophy of care to treat the patient, not the numbers. And so they need what they need.
Exactly.
Right. If they're fine with 3, then 3's plenty. Yeah. So.
Hi, Chris Acully from UW Seattle, Washington. I was just curious, for the patients that you said where you're considering alternatives besides like increasing the dose further than the 25 units of lipase per kilogram per meal, we do have some patients who are on about that 4,500 units lipase per kilogram because they self-titrate up. And they anecdotally report, I feel so much better. I keep my weight at this really high enzyme level. It just makes me cringe a little bit because I don't know what's going to happen to them in the future, long term. Can you guys speculate, or do you have any other options or recommendations to refer patients for GI, more frequent monitoring or anything like that when they're on high doses?
We definitely do more frequent monitoring on the patients who have to do that. So we have our GI doctor in clinic with us just one time a month, and we make sure those patients who are on the higher ends of dosing or still having GI problems to make sure that they only come to that clinic where the GI specialist is in there, so that they're seeing a GI specialist once a month or at least once every 3 months, that they're involved with a specialist all the time to keep an eye on that.
Do you know what your GI doc is looking for, symptoms or concerns?
Just how much, I guess, fat is in their stool, or what kind of GI problems they're having, if she needs to put them on H2s or PPIs or work them up for comorbidities like celiac and other things like that.
Thank you.
Sorry.
We have a few questions here.
Oh my goodness.
Have you looked at height philosophy versus just BMI? We have patients that transferred to us on very low dose and short stature.
We did not suss out any other data other than the BMI for this, but I think because of the results we got with this, we're interested in expanding that and in looking at things like height velocity.
And have you considered using alternative microbial source enzyme supplementation, taking into account these have proven to be more effective?
I have not, but we'll definitely look into that for our patients on the high side.
Have you noticed any changes in bowel habits when decreasing enzyme dosing? We have noticed a lot of constipation lately.
We have not. Just based on this is open the conversation within our team to talk about decreasing dosing on patients. And we haven't decreased anybody as of yet, but that is definitely something we want to consider. And like we talked about before, making sure they follow up with the GI specialist and following up more often in clinic as we're messing with enzymes.
Did you look at each individual's diet? Any fat gram-based enzyme adjustments?
We did not go that in depth to the diet. We literally just took how much they were on and what their BMI was.
As a dietitian, I'm looking more at symptom management, greasy stools, constipation, bloating, versus comparing their weight and BMI.
Which I agree, that's great. We were just talking, you have to treat the patient and not just the numbers. But we wanted to see if it was an interesting place to say, well, you're not having any GI symptoms and you're on 8,000 units lipase per kilo. Can we go down on your things and make you take less pills and without increasing symptoms?
Any difference between enzyme brands?
No, we did not compare that out either. But that's a good question, the enzyme brands. I think we have a lot more research we can do on this and kind of expand it now that we see that there's something going on.
That's it.
Okay, thank you.
Okay, thank you.